Welcome one and all who have assembled to listen to the research presentation for this PhD dissertation by Vavosi on evaluation of different pathological markers in predicting outcome of pyeloplasty in children with the uretero-pelvic junction obstruction. This work was registered at Sri Ramchandra Institute of Higher Education Research after getting necessary ethics committee approval. Informed consent was obtained from all patients and patient confidentiality has been maintained throughout. Hydronephrosis is being detected very commonly in fetal scans, and uretero-pelvic junction obstruction is an important cause of hydronephrosis. The increase in back pressure causes a rise of inflammatory mediators, which in turn cause tubular atrophy, fibrosis, and loss of function. There are multiple theories on pathological changes in uretero-pelvic junction obstruction. Excess collagen, muscle hypertrophy and hyperplasia, depletion of nerves in the muscle layers, muscle atrophy and hypoplasia, all those things have been proposed. Inflammatory cell infiltrate and fibrosis are often the effects which are seen on histopathological examination. Pyeloplasty is usually a successful operation. However, it has got a 5 to 7% failure rate even in expert hands. Poor technique, leak, and missed crossing vessels are supposed to be some of the causes. However, even in the expert hands where these particular problems have not been missed, there is a failure rate, probably due to incomplete excision of the narrow segment. The surgeons will know how difficult it is to assess the length of the segment macroscopically. Particularly in an infant, it is very difficult to say where the narrow segment stops and normal ureter starts. The uretero-pelvic junction obstruction itself is not a physical obstruction, but an adynamic segment, and there are multiple theories on this: decrease in interstitial cells of Cajal, decrease in neurons, increase in collagen, and decrease in smooth muscle have all been reported as the cause of this aperistaltic segment. The primary aim of the study is to evaluate the role of different pathological markers like interstitial cells, neurons, and the collagen to muscle ratio in predicting the outcomes of pyeloplasty in children with uretero-pelvic junction obstruction. The further objectives are to introduce a clinical assessment tool to assess the severity of the hydronephrosis, and then the main aim, the role of markers in the prognosis, then to look at the intraoperative markers to aid the surgeon in locating the normal ureter, and also to look at the fetal ureters to understand the pathogenesis. The power calculation was done before starting the study, and we needed around 15 patients in the control group and 30 patients in the study group to show the difference in number of interstitial cells or neurons or collagen. So the phase 1 was a retrospective study where all antenatally diagnosed hydronephrosis patients were included, and this was basically to look at the prognostication based on the radiological finding. Then phase 2 was the real study where the normal ureters of patients who underwent an nephrectomy for non-obstructive pathologies like a trauma or tumor were studied. Group 2 were involved the actual patients of uretero-pelvic junction obstruction who were operated, and the specimens were sent for particular analysis of both the narrow segment as well as the top of the ureter, which was anastomosed, which is supposed to be normal. Then phase 3 involved conventional staining and a frozen section staining, and phase 4 involved examination of uretero-vesical junction obstruction and fetal ureters. So coming to phase 1, how severe is hydronephrosis? This is a 2-month-old girl with antenatal hydronephrosis, 24 millimeter diameter, but however, the renogram shows drainage. The same patient at 5-month follow-up, the hydronephrosis has increased to 30 millimeter and the renogram doesn't show drainage. However, after the postoperative period, sometimes the dilatation persists and the parents often get worried. And the drainage curve also sometimes shows only mild improvement, or sometimes it remains flat. And we need a proper tool. For any reduction in size, we need to know where we started. If a size 5 becomes a size 3, that is a good improvement. However, what was size 3 becomes size 4 after an operation, that is not an improvement. So the aims of the study are to develop a hydronephrosis severity score for objective assessment of the severity, to analyze its role in assessing the severity of UPJO before surgery, and thus use it later for assessing the postoperative outcome. So ultrasound grading based on SFU is already graded 0 to 4. We also used the anteroposterior pelvic diameter, which was graded from 0 to 4, the worst being more than 30 millimeter. Then drainage pattern, a normal drainage is 0, good response to Lasix is 1, sluggish response is 2, and then no response is 3, and outgoing curve with the stasis at 2 hour delayed is 4. Then differential renal function was also given a weight of 0 to 4, with the worst grade being given for less than 30% function. So when we add all these three parameters, what we get is a HSS, which is A plus B plus C, the maximum score being 12, denoting the severe hydronephrosis. The mild one is 0 to 4, moderate is 5 to 8, and severe is 9 to 12. So this is a retrospective case record review of those patients with the unilateral hydronephrosis who were seen preoperatively. We excluded patients with vesicular reflux or ureterocele or mega ureter, or those with incomplete records or images. And ultrasounds and diuretic renograms were retrospectively analyzed during the first follow-up, second follow-up, and final follow-up before surgery by 2 blind radiologists and a surgeon. The actual outcomes were compared with the HSS predictions for resolution, persistence, or surgical intervention. So a total of 125 case records were studied. And if you look here, among those patients who had a mild hydronephrosis during the first visit, none of them eventually ended up having surgery. Whereas those with the hydronephrosis severity score of 9 to 12, all of them warranted surgery. So this is how they presented. The same can be applied postoperatively for assessing the resolution. I'll come to that later. We looked at intra-observer variation using Cohen's kappa, and we found that there was a very good correlation between assessors on this hydronephrosis severity score. So hydronephrosis severity score is a useful parameter preoperatively in objectively documenting the worsening and thus deciding for surgery. It is an objective tool during postoperative follow-up, and it can also be useful in reassuring those with the residual dilatation. It is also effective in quantifying postoperative outcome in terms of resolution, persistence, and recurrence. And if it is worsening at follow-up, it helps in the complex decision of a redo pyeloplasty. And this is what applied in our subsequent studies. So with that as a background data, we went with our prospective study of comparison of different pathological markers in predicting pyeloplasty outcomes. So the aim was to compare different markers like interstitial cells, neurons, and collagen to muscle ratio, both at uretero-pelvic junction and anastomosed ureter, compare them with the postoperative resolution, and then identify the best marker for predicting the prognosis. So group 1 involved control patients who had a ureter excised during nephrectomy for non-obstructive pathologies, and group 2 were the ones who were undergoing pyeloplasty for uretero-pelvic junction obstruction. The median age group was not statistically significantly different between the age groups. Specimen 2A was a uretero-pelvic junction narrow segment, whereas 2B was the ureter anastomosed, that is the lowermost part of the resected specimen. We always took a little bit extra for taking a small disc of ureter there. Only unilateral isolated uretero-pelvic junction cases were included. No cases with extrinsic obstruction like a lower polar vessel was included. No repeat pyeloplasties were included. Only those with no postoperative complications like leak or infection, and those with the full follow-up were included. Open dismembered pyeloplasty was done by the same surgeon using open technique. Laparoscopy cases were not included. So these are the three markers which I was talking about. Interstitial cells were the ones stained with the CD117 immunohistochemistry, also known as c-KIT. So these are spindle-shaped cells which are elongated at ends with the dendritic extensions, and the number of cells in 10 high power field were counted. Similarly, S100 is the immunohistochemistry marker for neurons, and these were dark stained cells, and number of cells for 10 high power field was counted. An independent pathologist who was blinded to the outcome of this patients was the one who was reporting the actual counting of the cells. Now, the collagen to muscle ratio was analysis was performed using Mason's trichomes technique, which stained the collagen blue and muscle red. So the color extraction technique was actually described by the Kim et al. And the area of interest is cropped, excluding the lamina propria and mucosa. And this image was uploaded into Tiny Eye Research Lab color extraction tool, which gives us into two colors of blue for collagen and pink for muscle. So all the patients were followed up at 3 monthly intervals with ultrasound, and final postoperative outcome was analyzed at 1 year follow-up with a diuretic renogram and an ultrasonogram. Improvement or deterioration was scaled based on hydronephrosis severity score, which I described earlier. Now, here you know how useful this scoring is. When you have an improvement in ultrasound grade, differential renal function, and improvement in drainage, you score them as excellent improvement. So 7 patients had that outcome. Then in 2 factors, the improvement was there in 16 patients. That's a good improvement. In 3 patients, at least 1 factor improved postoperatively. So that is still an improvement. In 3 patients, it was static, but in 2 patients, it worsened, warranting a redo pyeloplasty. So these are the results of the pathological outcomes here. If you look at the uretero-pelvic junction, there are hardly any cells seen here. Same is the case with the neurons, and the collagen shown in blue color is much more in the uretero-pelvic junction obstruction. So the past studies have only compared the uretero-pelvic junction obstruction, and some of them reported that they were all invariably abnormal, but they did not correlate with the outcome. Whereas if you look at the ureter, the number of cells are different. You start seeing a good amount of interstitial cells, neurons, and also the muscle as you go down in the ureter. So when we actually measure this and plot in the uretero-pelvic junction, there is a significant less number of interstitial cells compared to the control groups, and less number of neurons in the uretero-pelvic junction, and there is increased amount of collagen compared to the control group. Although the anastomosed ureter is matching to this normal control, it is still a little bit high because we are including all the patients who improved as well as not improved. Now, this is an important slide which describes the outcome versus interstitial cells. The x-axis shows the outcomes from worsening to excellent, and this is the number of cells. And the blue line represents the ureter, and this anastomosed ureter, and the red line represents the uretero-pelvic junction segment. As you see, the narrow segment has got invariably low number of cells, but the ureter, anastomosed ureter, shows a good correlation with the improvement. As the cells improve, the outcome also improves. Same is the case with the neurons. As the number of neuron density in 10 high power field improves, there is a improvement in the outcome as well. On the contrast, as the collagen decreases, there is an improvement in outcome. Here also you see that the correlation is better at the anastomosed ureter compared to the uretero-pelvic junction itself. So when we compare different pathological markers, the UPGO correlates poorer than the anastomotic ureter. If you see the anastomosed ureter, the R value is actually much more compared to the uretero-pelvic junction itself. Among all the 3 markers, the collagen to muscle ratio was the one which had the maximum correlation with the outcome. So it's a bit like having a good coffee. you may have sugar, you may have milk, so the neurons and interstitial cells may be needed, but the muscle, the actual coffee is the most important thing to have, and collagen to muscle ratio is a superior marker in predicting the outcome. So when we actually plotted the numbers in an ROC curve with the outcome, presence of more than 10 interstitial cells at the anastomosed ureter was found as a marker of success. More than 6 neurons at the anastomosed ureter was found as a marker of success, and the collagen muscle ratio less than 1.2 at the anastomosed ureter was also found to be a marker of success. So to summarize, sending uretero-pelvic junction for histopathology HNEL staining is only of diagnostic use. It often shows only inflammatory cells or fibrosis. Previous studies looking at the UPJO segment, they looked at markers at the UPJO which correlates poorly with the outcome. So they often did not show a consistent correlation with the outcome. Whereas sending the anastomosed ureter for the markers like interstitial cells, neurons, or collagen to muscle ratio is actually of a prognostic use. And collagen to muscle ratio is a superior marker than interstitial cells or neurons. Collagen muscle ratio is probably less expensive and more widely available because it doesn't need the immunohistochemistry. It needs a special stain. Coming to the phase 3 of this study, we wanted to look at a frozen section technique, the possibility of that. The aim was to develop a rapid frozen section technique for the CM ratio to identify the normal ureter distal to uretero-pelvic junction. So this is a prospective study, and the UPJ1 anastomosed ureter were stained both by conventional technique using Mason's trichrome as well as a frozen section technique with a modified Mason's trichrome. So the rapid Mason's trichrome technique is something which was adapted from the one described by Schaefer. The specimens were frozen with the freezing medium for and sections of 5 microns were made. The specimens were then exposed to trichrome stain for reduced time duration. So this is a recipe for Mason's trichrome. Basically, the trichrome stands for 3 different stains: Weigert hematoxylin, Biberg acid fusion, and aniline blue. And in the conventional method, around 60 minutes are taken for paraffin blocks, and further 1 hour, totaling about 2 hours is taken. Whereas in the frozen technique, around 10 minutes is taken for actual mounting of these specimens, and further 10 minutes, we have reduced this exposure time significantly. So within 20 minutes, we can actually do the analysis of this technique. There were a couple of challenges. It was difficult to get a wobbly UPJs on the cassette and reduce the freeze artifacts. In addition, to standardize the proportion of the 3 stains on Mason's trichrome was actually a challenge. It either became too blue or too red or some odd colors, and then freeze artifacts were there. So while we were doing our first study, the prospective study, the retrospective study, we were actually refining this particular technique using fallopian tube. And then finally, we could get the correct combination of the stains and the exposure time to get a differentiation in color. This is important because when we upload this correctly stained specimen, the cropped image into the software, it actually splits it nicely into the muscle, red for muscle and blue for collagen. So this is a conventional versus frozen rapid staining technique. So that is the uretero-pelvic junction, showing a lot of blue areas in both the conventional and rapid technique. And this is the ureteric end, where you can see a good amount of muscle, more than the collagen. And here also in the frozen section technique also, you can see a good amount of muscle there. So when we actually look at the numbers, they correlate. There's a strong positive correlation between conventional and rapid staining. When we look at the correlation with the outcome also, the frozen section technique, the results were correlating with the outcome. As the collagen decreased, there was an improved outcome in the pyeloplasty. So the validity of the frozen technique was compared with the conventional technique, and there was a 93.5% agreement between the conventional and the new technique which we have proposed, which has got sensitivity and specificity of 96 and 75%. So to summarize, this is the first study to show that it is feasible to intraoperatively identify normal ureter distal to the uretero-pelvic junction with a novel rapid frozen section technique. This could be particularly useful in recurrent UPJ cases where the surgeon might be keen to ensure that the ureter anastomosis is histologically normal. Now coming to the fourth phase of our study, here we wanted to look at the pathogenesis of uretero-vesical junction obstruction. We also wanted to study the fetal ureter to see whether there's any common theory of etiology. Uretero-vesical junction obstruction is also very similar to uretero-pelvic junction obstruction, where there is no physical narrowing, but there is an aperistaltic segment. So in addition to our PUJ segment and controls, we had a UVJ segment in 14 patients, and then we had 12 specimens of fetal ureter. So these were the fetuses where there was no associated anomalies or genetic disorders. So we looked at interstitial cells and collagen to muscle ratio, and as you see here, compared to the control specimens, the UVJ segment also had, like a UPJ, very low number of interstitial cells. Interestingly, the fetal ureter, the mid portion of the normal fetal ureter, also had very little interstitial cells. And when you look at the collagen, again, the uretero-vesical junction behaved very much like a uretero-pelvic junction, but the fetal ureter also had a lot of collagen in the mid-ureter. Now, this is a H&E staining. You can see normal ureter with a lot of muscle. This is a Mason's trichrome. Good amount of muscle is there compared to the collagen. In the UVJO, the muscles are in disarray, and there's a lot of collagen here. UPJO also a lot of collagen in both stains, and fetal ureter also. There's a plenty of collagen and very little muscle there. One more finding interesting was, as the gestation progressed, the interstitial cell density increased in the fetal ureter. So the younger the fetal specimen where there was less interstitial cells, and as they progressed with the gestation, there was more cells. Similarly, in the collagen to muscle ratio, as the gestation progressed, there was a decrease in the amount of collagen. So this made us think that the ureter remains as an epithelial tube until late gestation, and the ureter maturation involves replacement of collagen matrix by smooth muscle cells and interstitial cells. And this process probably starts in the mid-ureter and extends to both ends. Failure of this maturation at the top end leads to uretero-pelvic junction obstruction, and the failure of maturation at the bottom end leads to uretero-vesical junction obstruction. The genetic studies also support this fetal ureter maturation theory. 27 weeks is the time around which the smooth muscle cells start differentiation and start appearing in the fetal ureter. So to conclude, from all these 4 studies, the first one, we have introduced a new grading system for objective diagnosis of success or failure of surgery. Then collagen to muscle ratio, we have found as the best prognostic marker for and it's more useful than interstitial cells or neurons. We have also found a novel rapid frozen section technique, which will help to locate the normal ureter during the treatment of uretero-pelvic junction obstruction. And the fetal ureter maturation theory explains the pathogenesis of uretero-pelvic junction and uretero-vesical junction. So although we started initially our main aim being the prognosis, we have also, as a corollary, found some evidence of different tools in diagnosis, treatment, as well as the pathogenesis. There are some limitations for this study. The study conclusions are based on small numbers, and larger studies are needed to validate our findings. Frozen section technique has got 20 minutes waiting. Would surgeons be keen to wait? I would proceed with the pyeloplasty, and if the pathologist calls with the good news, then I'll sleep well. What if the ureter is reported abnormal? Would you reopen the wound and excise more? What if it is a true long segment? Can they actually excise more? Or they can use some alternative techniques like spiral flaps or ureterocalicostomy. So these are some of the thought processes which will go through the surgeon's mind, and we still don't have answers for this. But our study is an eye-opener for these kind of concepts to develop. So the existing methods are giving 95% success. So some people may ask, why should we change? But at least in redo cases, they can adopt this method. Now, any innovation or research, it takes time, and it took around 40 years for the flight to evolve from the original model proposed by Wright brothers. It was in the year 2000 when the South Korean authors Kim et al. Proposed the collagen to muscle ratio in uretero-pelvic junction obstruction. Harish Jairam and Kailan Rao in 2003 was the one who looked at the neurons, and they felt that around 7 millimeter more of ureter has to be excised from where you feel it is abnormal. And Solari and Prempuri looked at interstitial cells using c-kit immunohistochemistry in 2006. And our research have compared all the three above and found that the collagen to muscle ratio, the old one, which was described in 2000, was actually superior to the later ones. Mason's trichrome technique is cheaper. It is more popular and widely available than immunohistochemistry, and that may be another reason why this technique also is feasible in all centers. We have also shown that frozen section diagnosis is possible, and 20 minutes is the time it takes now. But a future refined kits along with the mobile apps may actually shorten the duration further. So this research has been presented in many international conferences. The fetal ureter theory was presented in the pathology conference. Similarly, rapid special staining technique was presented in the pathology conference. Then the role of markers in the prognosis was presented in the International Congress of Asia Pacific Association of Pediatric Urologists, and hydronephrosis severity score was presented in the National Conference of Indian Association of Pediatric Surgeons in 2018. We have also published this in international indexed journals. The hydronephrosis severity score was published in the Journal of Pediatric Urology, International Elsevier Journal, and it has already got 760 views and 7 citations. The fetal ureter histology has been published again in Journal of Pediatric Urology. It has got 300 views and 6 citations. The comparison of different pathological markers, that paper has been published in the Journal of Pediatric Surgery, another international Elsevier journal, and the rapid technique, staining technique, has been published in the Journal of Pediatric and Developmental Pathology, another international journal. We have applied a patent for our rapid frozen section technique, and hopefully we will be able to substantiate this. Future research in uretero-pelvic junction, ultrasound elastography in postoperative prognosis. We have actually completed this particular research project and published in the Indian Journal of Urology. Morphometric analysis of uretero-pelvic junction, this is underway. Then urine biomarkers in prognosis of uretero-pelvic junction obstruction, including NGAL and MCP1. We are planning to apply for funding, and probably a multi-institutional research project we will be starting with the JIPMER. I dedicate this research to my parents. They've always encouraged me to dream big. Even a village kid like me can aim high for a doctorate, and that's what they've dreamt. My sincere thanks to the management, chancellor, pro-chancellor, vice chancellor, dean of research, dean of faculties, dean of education, and academic officer. I'm greatly indebted to Professor Venkatasai, who has been a friend, a guide, and more than a philosopher, like an elder brother, encouraging me to take up this PhD project for more than 10 years now. And I thank Professor Venkatramanan and Professor Rajan, who has been my guide. Profound thanks to pathology department. These are all the great pathologists of our department in the eosine and hematoxylin colors here. And they have been an excellent support, and these are the pathologists from the International Forum. Professor Sandhya Sundaram, HOD, has been really helpful in particularly propagating this fetal ureter maturation theory. She was the one who came with that idea. And Professor Rajendran helped me in designing the rapid frozen section technique. Then Dr. Sai Shalini, her interest is in fetal pathology, so she was the one who helped me stay in fetal ureters. Dr. Pavitra has been instrumental. She's the one who was a blinded pathologist, not really blinded, but she was actually keeping her eyes open and then counting the number of cells for my study. Then Dr. Manjusha has been grossing the specimens for me, and Mr. Chellappa and Ms. Anuradha has been preparing the actual Mason trichrome stain, which is actually a demanding procedure. It's like making a proper broth, and if it is not done properly, you lose the taste. I also thank Dr. Venkata Chalabadi, Nuclear Medicine Department Chief, Dr. Mahesh and Dr. Aruna of Anesthesiology Department, Ms. Gayatri, my statistician who has helped me with in various stages, and Ms. Kulsum who has helped me in the patient support. I dedicate this work to all my patients. The entire work is of the patients, by the patients, and for the patients, and this work exists for them. Thank you very much for listening to me patiently.